Okay, I'm back and I am joined by a large cohort of the DEI Focus Group. We've got Dr. Helen Williams from CHOA, Dr. Nikki McLaughlin from CHOA, nurse practitioner, Dr. Emily Fisherman from St. Louis Children's Hospital, and Dr. Downey from Children's of Minnesota. So, welcome, you all. Thank you for being here. Obviously, quote unquote DEI is becoming a very hot topic. Thankfully, finally, we're addressing this in medicine, but especially in neonatal care. Maybe somebody just wants to get us started. For people who still don't understand what DEI is, why is it so important? Why are we talking about it?
Great. I'll start. So, diversity, equity, and inclusion. I think it is particularly important since we are dealing with relatively rare neonatal diseases at our level 4 hospitals that often can disadvantage individuals that come from underrepresented minorities. And specifically, we're dealing with large metropolitan areas where our children's hospitals are located. And so that puts our rural infants at a disadvantage. And since we have so many important advances in neonatal medicine, I think it's important that we make sure that those are being distributed equitably and that all of our babies see the benefits of the great work that's going on both at the CHNC and at our individual member hospitals. And so I think as like-minded individuals, the four of us kind of got together at the same time and decided that CHNC was really ready for a group that focused specifically on initiatives. And I think we're excited that this is our first conference, our first symposium where our group has been active, but we're really excited to bring this focus to the Children's Hospital Neonatal Consortium.
I love that. So I have here the vision for the focus group. The DEI focus group aims to create a NICU environment that is respectful, accepting, and accommodating of all patients and families, regardless of their background or beliefs. In doing so, we endeavor to foster a culture of family-centered care that promotes equitable outcomes for all critically ill neonates, which is a lovely, lofty goal that you all have. I wonder, one of the things I have a question about specifically is exactly what you talked about, access to care. So there are so many neonates born all over the country who may have difficulty even getting to one of the major level 4 institutions. And why is kind of access to care so critical for these complex babies?
Go ahead. No, you go ahead, Nikki.
No, go ahead.
I think, it's really critical. I work in an institution in an area of the country where we do see we have babies that come from 400 to 500 miles away. Yeah. And our biggest challenge, specifically I have a lot of passion in human milk and having those families provide human milk for their infants. And when our families have to return back to their home, based on their own internal resources or other children, job, a lot of our families have to return to work while their children remain in the NICU. It is extremely challenging, the limitations that we're able to provide them for transportation, housing, food, to be able to sustain them while their infant remains in the NICU. So I think it's really crucial for us to really look at the community resources that are already currently available. In our own institution, just even having WIC resources available for our families is crucial. We finally have those on our own campus for our 150-bed
Wow.
NICU, which we had not previously had. And that's just our urban population, but, really trying to reach out into the community and see how we can keep those families within their homes so that they can be supported there while we support their infant in the NICU.
Yeah, I love that. Especially this line, and echoes what you said, this family-centered care. We know that families are critical to the well-being of their babies. And if we can't get parents at bedside for a number of reasons, that those outcomes will be less than they could be. And so I'd really like you guys to underscore that I think some people feel like this DEI is a very big topic that is bigger than a singular person, bigger than a single institution. But it sounds like there are some even small changes we can make, boots on the ground, that help improve kind of equity for our families with the long-term outcome of having family-centered care. It sounds like we can't have family-centered care without having more equity, or at least thinking about those topics in our unit. I don't know if somebody wants to speak to that.
Yeah, so we, our initial sort of academic research project for our focus group has been to do an assessment, a formal assessment of cultural awareness and resource evaluation and availability in our 49 member hospitals. And so that looks at not only the common or commonly thought of areas of DEI work, including race and ethnicity, of course, but it also looks at communication practices. Who communicates with families, right? Like, do they get a daily update? Is it by phone? Is it in their primary language? Who decides what their primary language is? Who decides how comfortable they are with receiving those updates in that language or our commonly spoken English, right? Who is asking about religion and parent pronouns? Are laundry services available? Are all sorts of social determinants of health, but also just general care of our families. And so at the moment, we've had about a 50% response rate. We're going to do some focused work to try to recruit more of our member institutions to really formally describe this, and then start to figure out what changes we can make within the consortium.
That's a reminder for everybody, if they haven't returned their survey, that the DEI focus group is looking for you. One of your goals is making sure we establish a diverse and multidisciplinary group of healthcare professionals to address inequities. So why is it important that we have diversity in our healthcare teams, especially in the NICU?
Yeah, I think that bringing in perspectives of all of the different disciplines and really looking at this problem from different vantage points is going to provide more information, more context, and ultimately better ideas, more ideas on how we can really support and help our families during this time. And I think that, while the NEOs may bring this, the practitioner team may bring that, of course, nursing has the most face time with families and our patients. So, of course, they have a perspective that needs to be considered as well. So when you bring all of that together, I feel like you can definitely make a more strategic and better tailored plan for how you're going to address inequities or how you're going to provide resources or improve access to resources across the board.
Like that. Well, I would be remiss if we didn't talk a little bit about the workshop that you guys are holding regarding addressing healthcare disparities from the start, integrating social determinants of health screening in the NICU. Why is screening for social determinants of health important?
Well, I think that's another group that are holding, that are doing that.
You guys
that session.
That's fine.
Yes.
That's fine.
But we do think it's very important.
It's very important. What is your call to action then for people who are listening and might be interested in helping support the mission of the focus group?
Well, since we just recently got started, we are certainly recruiting for members, and we would love to have representation from several of our sites, ideally all 49 if possible. So
that would be a very big group.
That would be the first thing that we would say as part of our call to action. And the second part is just an acknowledgement of the importance of including the diversity, equity, and inclusion in our efforts. I think we will be one of those focus groups that a lot of the work that we do moving forward will be with other focus groups. And we're really interested in making sure that we can help add that perspective to the ongoing work of our colleagues in disease-specific focus groups so that we can work to best serve all of our patients. And I think everybody in the group said it really well. In order for us to do the best job possible for our families and to provide truly family-focused care, we need to consider the family of origin and how important that is in the shaping of our patients' not just as patients, but once they leave the NICU. And I think that this diversity, equity, and inclusion focus will be one that will really enrich the activities of the CHNC. And I'm so thankful that you invited us to come to the podcast today so that we could share our focus and our efforts moving forward.
So what I hear you saying is that DEI is not a standalone subspecialty, and that regardless of our research, focus or QI or what we're doing in the unit, that we have to be paying attention to these other kind of underlying things that families bring to the unit with them. Is that right?
Precisely.
Okay. I like that. You said something else about kind of family and origin and understanding what our individual families need. So what is something that people can do on rounds, something that they can take to the unit tomorrow to start making cultural change, no pun intended about cultural change, but a systematic change in their unit by being a role model of addressing a way to connect with families in a culturally competent way, knowing that that's different, right, for different families, but in general that families want to share their stories.
I agree. I think, really including the family and asking the family. I think trying to avoid any assumptions. I think historically we, as providers, we're trying to make it through the day. And, every baby, we see a lot of acuity and we have to, do all of our daily tasks. But I think we need to step back and, if we can ask the family, include the family in both education, discussions, decision making. I'd like to take a lot of time to talk through families and be like, this is what I'm thinking through my differential versus just going through your usual assessment and plan for the day. And then modeling that, most of us work in a hospital with trainees, whether that be fellows or residents or nurse practitioner or PA students. And, modeling that for our trainees, because it's really important to learn not just the material that and the physiology and other things that we do in our day-to-day practice, but it's also important to model that behavior, to know that we can do better, because if we can do better and we can provide better family-centered care, we're going to have better outcomes. Our families are going to be more satisfied. Our families are going to be home quicker, hopefully. Our babies may be healthier. So I think that's really crucial.
And I think amongst ourselves, doing things like personalizing the baby and not the baby in such and such room. What is the baby's name?
Love that.
And being
what are the
intentional.
parents' names?
Correct.
Yeah.
And
How do you say them correctly?
That's right.
all of those type of things that are very simple, but at times we can kind of forget and just quickly be like, oh, that kid in room 4 needs X, Y, and Z. So, making sure that we are being mindful of treating the baby as a person and not, a to-do.
Yeah, I love that. I think that's such an important tip. I think it doesn't matter what culture you come from. Names are so important. And I think that's such a way we can honor families and respect our patients. People can, today, if you're listening, you go on rounds, you better be using parent and baby names. I love that. Well, thank you all so much for the very critical work that you're doing. I can't wait to see how it intertwines with all of the other work being done at the CHNC.
Thank you for having us. Appreciate it.
This was fun.